There is some stuff already recorded, and just in case we don't get to reproduction, that is recorded already, but hopefully we should be okay. So we're going to start with osteoporosis. So let me just be sure I'm sharing. And for this, we need to think about both calcium balance and the structure of bones, because they're related, and two of the medications that we can use for osteoporosis are also used for treatment of osteoporosis. They're also used for treatment of calcium. So we'll start with just talking a little bit about calcium balance. Just bring a slide in here. So calcium per ATI should be about 9 to 10, around there, 9.5 to 10 or 9 to 10.5, something like that. You won't have to memorize it for, at least for my exam. If the calcium level gets too high, that can be bad for the body. Extra calcium can lead to kidney stones. It could lead to abdominal pain and constipation. It can change people's mood and cause symptoms like that. If the calcium level is too low, then people will experience symptoms that are muscle tingling, twitches. The tingling or paresthesia feeling most commonly begins in the fingertips and around the lips, and the muscles will get tremulous. And the worst thing that can happen is something called tetany, where the muscles remain contracted, and that means the skeletal muscles, but also the heart. So in order to maintain balance, the body will do things to either decrease the amount of calcium available or increase the amount of calcium available. And that definitely involves the bones, because the bones is a source of calcium. It's inside the bones. So if the calcium level gets too high, we release a hormone called calcitonin from specialized cells in our thyroid. And if the calcium level gets too low, we release a hormone called parathyroid hormone.
Hi, Dr. Schultz. Sorry, really quick. Where are you getting this PowerPoint from? I was trying to look for it. It's not in your email that you sent out for our lecture today.
It should be in the calendar. So if you
Okay.
go to your Outlook calendar, it should
Mhm.
be in all of the PowerPoints, including the ATI, and the rest should be there.
I do see
Hey, Kim.
ATI, glaucoma, GI, and reproduction, but no osteoporosis.
Oh, I'm sorry.
That's what mine had as well.
Okay, I will add that.
Thank you.
I don't, if the osteoporosis isn't there, let me see.
Check drop down. Okay, let me check it.
It could be that I didn't do it too. I mean, that's always possible. Because I can add it really fast.
No, it does say 4 attachments, so I see the 4. It might just not have the osteoporosis in there.
Probably not, so we will do that.
Thank you.
Mm-hmm. You can see my computer has like absolutely no rhyme or reason. It's just a osteoporosis. Okay. Oh, there it goes. Okay, so now it should be sent. Okay, so the parathyroid hormone, if the calcium level gets too low, the parathyroid hormone will increase bone breakdown by activating cells called osteoclasts, which help break down bone. And if the calcium level gets too high, calcitonin will decrease bone breakdown. by stopping the osteoclasts. And osteoclasts are special cells in bone that help with breaking down bone and bone recycling. So the bone is made of three types of cells: bone cells, or osteocytes, osteoblasts, which are cells that form bones, and osteoclasts, which are cells that break down bones, because the bones are constantly going through recycling. The osteocytes wear out, they're destroyed by the osteoclasts, and new cells are born, and you completely remodel your skeleton every 4 months. The bone also contains calcium and phosphorus, which adds strength to the bone, but is also a storage depot, especially for calcium for us. So the other thing that parathyroid hormone does, besides break the bones down to get more calcium, it also activates vitamin D in the intestine to increase absorption of calcium that we eat. So that's why it's always good to take vitamin D with your calcium. And it also tells the kidney to save calcium. So that's how we end up with more. So again, if we have too little calcium, we get that tingling sensation, especially around our mouths and fingertips. We can have twitching or spasms of muscles. And if the calcium level gets too high, you can experience confusion, depression, kidney stones, abdominal pain, and a change in urine output. So if the person develops hypocalcemia, maybe they're not getting enough calcium in, or they have other health problems, you can replace calcium. And the main calcium replacement we're going to talk about is calcium carbonate or calcium citrate. Calcium carbonate can also be used to neutralize stomach acid because it's Tums. And so you can replace calcium that way, and you can also give it to prevent osteoporosis in a person that is at elevated risk for it. So calcium replacement could be calcium carbonate or calcium citrate. There are other forms. These are the oral forms of calcium replacement. There's calcium gluconate that can be given IV. There's all kinds of calcium replacement. Calcium carbonate is the one that you're going to see on the exam, which works better with the addition of vitamin D because, put stars by that, because vitamin D increases the absorption of calcium in the intestine. So if I'm going to take a calcium pill by mouth, it has to be absorbed in my intestine, and I will absorb more if I take it with vitamin D. Calcium citrate or Citracal comes in pill or chocolates. The pill can just be swallowed. The chocolates are obviously chewed and swallowed. Tums are chewed and swallowed, and then with a full glass of water. Because you're taking calcium, it can alter the absorption of other medications, so you should separate it from other medicines. If the person develops hypercalcemia, meaning that their calcium level is too high, you can give medication that will help eliminate the calcium from the body. And this particular medication can also be used in osteoporosis, which might seem kind of weird, but it's because the medication that's similar to our own body hormone, calcitonin, will stop the work of osteoclasts. That means we're going to not allow the bones to be broken down. But that also means we're going to decrease the amount of calcium that's put into the bloodstream. So it can work for both. So if I'm giving this for people with calcium levels that are too high or with osteoporosis, I would give one spray in one nostril daily. So people might say, on the even days, I'm going to do the right nostril. On the odd days, I'm going to do the left nostril. It's kept in a dark bottle and refrigerated. So calcitonin salmon is the preparation that's given to people, and it's made from fish, so you can use it to treat increased calcium levels, and you can also use it to treat postmenopausal osteoporosis because it stops the activity of osteoclasts, and it increases excretion of calcium in the kidney. So you get rid of calcium and you stop bone breakdown. But you obviously cannot be allergic to fish since it's made from fish. So if the patient has a severe allergy to fish, then they could become anaphylactic by using this medication. So sometimes they will even do allergy testing because you're stopping the absorption of calcium and decreasing bone breakdown. The patient could develop hypocalcemia. So it's good to be sure you remember both hyper and hypocalcemia. Because you're giving it in the nose, you could have the symptoms we've talked about for a while, which is when you give nasal inhalations that it might be irritated, you might get dryness to your nose, you might get sores in your nose. The person can treat that by using humidification or something that will moisten the air. The patient should also be told to give the nasal spray correctly towards the earlobe so that it absorbs on the nasal membrane. And this is just another picture of what osteoporosis is. We talked about osteoblasts building bone and osteoclasts breaking bone down. When someone develops osteoporosis, it's that the bone breakdown is greater than the bone build up instead of maintaining a balance, so their bones get very thin. These are the risk factors for osteoporosis, which can be related to menopause, so it's very common for women as they age. There is also the possibility that men, as they get older, will also develop osteoporosis as they lose testosterone, but that occurs much later for men than it does for women. It could be that the patient isn't getting enough calcium and vitamin D in their diet, or they're taking medications like prednisone that increases bone breakdown, or have some other risk factors. So if the person has osteoporosis or is at risk of it, we know we can tell them to use calcium supplements, preferably with vitamin D. We know they could take calcitonin as a possibility. The last two medications would be Relaxified and alendronate as the other possibilities. Relaxified, the brand name is Evista, is a selective estrogen receptor modulator. And we talked about one of those medications before. The other SERM, or selective estrogen receptor modulator, that we talked about was tamoxifen. In the setting of tamoxifen, we talked about it as one of the chemotherapy agents. It was a pill that could be taken for people that had breast cancer and had already undergone treatment. Then they could use that pill to block estrogen receptors on breast tissue and prevent recurrence of breast cancer. Or if they were at high risk of developing breast cancer, we could give it to them to block estrogen receptors in the breast to prevent breast cancer from developing. This medication also could do that. It does block estrogen in the breast too, but it activates estrogen in the bones, and estrogen helps promote bone growth, and so that can decrease postmenopausal osteoporosis. It's best to do it with calcium and vitamin D and weight-bearing exercise, but we have to separate Relaxified from calcium and vitamin D. It's taken orally daily with or without food. So when we talked about tamoxifen, let's see here. Oh, thanks, Lakeisha. I will mark you down. Just to let you know, the original email I sent out with the PowerPoints did not have osteoporosis on it, so I sent a second one which does have osteoporosis, just in case you don't have that. Oh, it looks like Stephanie is also... Oh, maybe my computer is being slow. Unless I put it in the wrong class, which is also possible. Let's see. Maybe I did that. Try that again. Oh, that's okay. I probably attached it to Tuesday instead of Monday, but hopefully you get it now. At least it's recording. So when we talked about tamoxifen, or we talked about selective estrogen receptor modulators before, the thing about them is that they activate some estrogen receptors and block other estrogen receptors. So tamoxifen blocks estrogen in the bones, blocks estrogen in the breasts, but it actually activated estrogen in the uterus, which makes it an increased risk. It increases the risk of endometrial bleeding and endometrial cancer, which I think might have been a question on the ATI as well, I'm not sure. But Relaxifene blocks estrogen in the uterus, so we don't have to worry about the increased risk of endometrial cancer. We do, however, have to worry about a possible increased risk of clots, and that's the main issue. They will probably have hot flashes. That also happens with tamoxifen. So just as a review, since tamoxifen could be on any of your exams, tamoxifen blocks estrogen in the brain, which is how you get the hot flashes, and in the breast, but activates it, which leads to clots, and activates it in the uterus, which could lead to cancer risk, endometrial cancer, and people on tamoxifen also have to watch their vision. Relaxifene is a little bit safer because it blocks estrogen in the brain and the breast, so you decrease breast cancer risk, and you will unfortunately get hot flashes. You increase your risk of clots, but you don't have to worry about the uterus or the eye stuff. Or the eye stuff. It is a pregnancy category X, which means a person cannot take it if they're pregnant. And most people will be taking relaxifene as postmenopausal anyways. The last group of medications for osteoporosis are bisphosphonates, and this by and large is the one that is usually prescribed for osteoporosis. It's the most common one. They all end in dronate except for the one that's given IV. So our prototype is alendronate. You might see other types listed on the ATI, but they always end in dronate. And what this does is it decreases the number and action of osteoclasts. So it could be used to treat postmenopausal osteoporosis, but also age-related osteoporosis in men and steroid-induced osteoporosis. So it has a lot more uses. It has some directions. It's an oral medication taken every day. It has to be taken prior to anything by mouth, no other medications, no breakfast, with a full glass of water, and you cannot you cannot lay down for 30 minutes after taking it. You should be sitting or standing. So that's extremely important directions. You take the medication, full glass of water, first thing in the morning, and then you have to remain upright for a full 30 minutes. And that's because these medications increase your risk of esophagitis, which is inflammation that could potentially lead to ulceration of the esophagus. So you're trying to prevent that. Some people will have a little nausea and vomiting, but that's different from the severe type of heartburn that you could also experience if you're experiencing the esophagitis. Muscle and joint pain are common. The patient should be instructed to keep stretching. This is different than the muscle and joint pain that we talked about, or the muscle pain that we talked about with the atorvastatin, the cholesterol medication. That could actually be related to muscle breakdown. That's when we were worried about the patient CPK numbers elevating and potentially causing a type of kidney disease. Here, we don't have to worry about that at all. It's just that the muscles get sore, so they need to stretch. And they could take an over-the-counter medication to help with their muscle discomfort. The adverse effects of the esophagitis, like we talked about, and any vision changes. So that's osteoporosis. So I'm sorry about that slide issue. Does anyone have any questions about that material? So the 4 medications are calcium carbonate, calcitonin salmon, relaxifene, and alendronate. And so then we will go over glaucoma medicine. And I still want to just be sure, because I did get Stephanie and Lakeisha, but I don't, just to be sure, Katie and Mai, if you're here, let me know. Yes, I'm recording. Okay, so glaucoma. The first thing to review about glaucoma is oh, thanks, Mai. I just want to be sure I give people credit. Is Katie here? Because I don't have you yet. Um, the first thing is all of the medications for glaucoma are given as eye drops, and you don't want them to systemically absorb. You only want them to reach the eye, the area that's causing a problem. So the proper installation of eye drops is very important. And the key thing is this. In order to decrease systemic absorption, either the patient or you has to place their finger here along the side of the nose near the inner eye in what is called the nasolacrimal duct. So tears are made in the lacrimal gland, and they flow across the eye and are drained through this nasolacrimal duct into the nose, which is why when you cry, your nose feels runny, because more tears are draining into your nose. So if you allow the medication to drain into that nasolacrimal duct and into the nose, then you have the possibility of systemic absorption if the medicine rests against the nasal mucous membranes, just like when we were talking about calcitonin salmon. We wanted the medication to, absorb on those membranes. This time we don't. So you have to place pressure on that nasolacrimal duct. So be sure that you're remembering that. Glaucoma is a change in how the aqueous humor, or the fluid that's in the back of the eye, drains. If there's too much fluid and it's not draining properly, then there's more pressure in the eye, and that will cause too much pressure on the optic nerve and eventually could lead to blindness. So if this is your eye, and you have your lens and cornea and iris, there's a canal right here next to the iris. Inside this part of the eye, there's the fluid, and the fluid goes through the pupil, which is that empty space, kind of bathes between the iris and the cornea, and then drains into what's called the canal of Schlemm, so that it can go into the veins and be taken away from the eye. So the tissue that's right here makes the fluid, and then it's kind of bathing the inside of the eye and protecting the retina, and then going through the pupil, bathing the inside near the cornea, and then draining. If for some reason this is blocked, or there's a change in how this fluid is made, then you can have an increase in what's called intraocular pressure, and that's what causes the pressure on the optic nerve. And so the way to treat it is either decrease the amount of fluid that's being made, or increase the drainage to take away the fluid, or a combination of both. And that the first two medications are usually combined because they do work together, decreasing the fluid and increasing the drainage to help decrease the pressure and thus prevent blindness. And that's just the same information about what glaucoma is. The first two medications are the ones that people are more commonly prescribed. The last two, however, still could be prescribed, and they are on the ATI. Prostaglandin analogs, which is Latanoprost, beta-adrenergic blockers, which is Timolol, cholinergic agonists, Pylocarpine, and cholinesterase inhibitors Phospholine. So these are both cholinergic medications, which kind of reminds us a little bit about the neuro unit. And this is an adrenergic medication, an anti-adrenergic, sorry. So just keep that in mind because that helps explain some of the systemic side adverse effects that could occur since we're activating the parasympathetic nervous system or potentially deactivating the sympathetic nervous system. So latanoprost increases the outflow of aqueous humor. So that's how we decrease the intraocular pressure. So we increase drainage. So you instill the eye drop, wait 5 minutes before instilling the second drop, because usually it's 2 drops. You should take the eye contacts out prior to instilling the drops, and then you shouldn't put them back in for at least 15 minutes. If a patient has been on this, they might notice like an allergy sensation or foreign body sensation in their eye, so they get the itching, dryness, and you can get a change in the length of the lashes and darkening of the iris. The systemic symptoms increase the risk of respiratory infection, could lead to chest pain or muscle and joint pain. Timolol decreases the formation of aqueous humor, so it decreases the amount of fluid. And that's why latanoprost and timolol are taken together often, because they do both work together very nicely to bring pressure down by both ways. So it's given 1 to 2 times per day. The patient might not notice, or the pressures might not change very much for a couple of weeks. So it could cause some stinging, burning eye pain. If systemically absorbed, could lead to hypotension, bradycardia, and bronchospasm. And this should make sense because it is an olol. It's a beta blocker or anti-adrenergic, meaning we are blocking the effects of the sympathetic nervous system, specifically on beta receptors, and beta receptors are located on the heart and lungs. Alpha receptors are on the vessels. Beta receptors decrease blood pressure. If we block those receptors, we can decrease blood pressure because we decrease heart rate, which means there's less volume that goes into the vessels. We decrease cardiac output, so we decrease blood pressure. And bronchospasm is because when beta receptors are activated in the lungs, the tubes open. If they are blocked, the tubes constrict, and that's what causes the bronchospasm or coughing that the patient might feel. So these were some of the side adverse effects that we talked about when we talked about metoprolol, because we want to bring down blood pressure, but we don't want it to bring it down too low. We want the patient for their heart rate to go down, but not too low, which is why we always check their pulse for a minute prior to. So, but if we put our finger on that nasolacrimal duct, or they do, then you decrease the risk of those systemic effects. The next medication is pilocarpine, which causes the pupils to constrict, and that opens up the network near that little canal in this picture to promote drainage. So when we talked about medications that you have to avoid in the patients that have glaucoma, medications that dilate the pupil kind of shrink this muscle. They make it smaller, kind of bunch it up on the sides, and if you bunch up the muscle, then you block the canal. So when you dilate the iris, you're kind of bunching up the iris muscle next to where that canal is, so you can decrease drainage, which is why we wanted to avoid medications that either activated the sympathetic nervous system or blocked the parasympathetic nervous system for patients that had glaucoma. So hopefully that sounds familiar, because that was from the neurologic unit. If the pupils constrict, then the muscle in the iris gets a lot thinner because the pupil is smaller. So then it's easier to drain because we open up that area. We're not blocking it with our bunched up muscle. And so the pupil, if the pupil is constricted, then we can help promote drainage. So side effects we would expect with a constricted pupil that they are going to have trouble seeing at night because we need to be able to open our pupil to let more light in. And they might have trouble seeing far because, again, we have to dilate our pupil to see further away because we're constricting the pupil. And they might develop a headache. But because this is a cholinergic medication, we want to prevent systemic absorption because we can get bradycardia, potentially low blood pressure. This might increase the bladder contractions. We might feel like we have to go to the bathroom, and it could promote bronchoconstriction, which means the person could have bronchospasm or coughing. So that's why we do that. The other thing is if you really constrict the eye, that can lead to retinal detachment, and that means that the retina falls away from the back of the eye, and the person can have like floaters in their vision, or sometimes it feels like a curtain is falling over the eye. And then the next medication is Phospholine. And this medication is considered a cholinergic because it increases available acetylcholine. And the way that it does that is, so this should be a throwback that you should remember from the neuro unit, is we have this first neuron, the presynaptic neuron, and here's the synapse, and then the postsynaptic neuron, or the second neuron, and this has vesicles that are the storage for acetylcholine, the neurotransmitter. And if the parasympathetic nervous system is activated, then acetylcholine ends up in the synapse, and that activates the next receptor or gland or smooth muscle or sometimes skeletal muscle in the setting of acetylcholine. So the way that I get rid of a neurotransmitter is either to recycle it by reuptake, or because an enzyme that is available will break it down and get rid of it. So hopefully that sounds slightly familiar. If I block this enzyme, then there'll be more available acetylcholine in the synapse, and for this medication that means increased acetylcholine means pupil constriction. It's just another way, instead of activating cholinergic receptors, this is another way that we can increase pupil constriction. The other medication that we talked about that inhibits the enzyme cholinesterase or acetylcholinesterase worked in the skeletal muscle. Does anyone remember what that medicine was? The medication that inactivates cholinesterase? Well, donazepam is another cholinesterase inhibitor. That wasn't the one I was thinking about, but that's correct. That happens in the central nervous system to increase the available acetylcholine in the frontal brain. So that does count. There was one that we talked about that was a cholinesterase inhibitor that affected skeletal muscle. And this way we could treat myasthenia gravis. So Scott's medication is a treatment for Alzheimer's. Do you remember the drug that we used to treat myasthenia gravis? Scott is trying again, it looks like. Yeah. So pyridostigmine is one. Neostigmine was the one that was mentioned on ATI. Those are medications that increase the available acetylcholine in the synapse, hopefully in the skeletal muscle, so that we can increase muscle activity. So that it's just another type of those medications. So I can expect the same side effects and adverse effects because it's doing the same thing as pilocarpine. It's just a slightly different mechanism. So I'll still have the frontal headache with changes in night vision and farsightedness because I'm constricting the pupil. If I have systemic absorption, I could still get bradycardia, hypotension, bronchoconstriction, urinary urgency. That's all possible. Constricting the pupil can lead to retinal detachment. In this setting, when I'm doing it for a long period of time, the only difference between these pilocarpine and phospholine, besides exact mechanism of action, is that phospholine can increase the risk of cataracts. So I helped my vision by decreasing pressure in my eye, but I just caused a different eye problem. So I still see pilocarpine used, but I have not seen phospholine used in a long, long time, but it's still on our stuff. So, okay, well, that is glaucoma. Does anyone have questions about glaucoma before we take a little break? Okay. Well, so it's almost 1:45, so we'll go to 1:55 as our break, and then we'll get as much done as we possibly can. So see you at 1:55. I'm going to pause this.